home, and Dr. Samy is going to speak to us about paradoxical issue, which is the systemic hypersensitivity to antihistamines and corticosteroids.
Thank you very much. Well, I have good news for you first, that those colleagues who are on the last 4 rows, they have been promoted to first-class seats here. So you are welcome to come, because when I was sitting in the back, I could not see some of the content. So if you would like to move forward, you are welcome, and I would appreciate it so that I can interact with your faces as well. Well, I thank Dr. Bahna for her kind invitation, and I really mean it. I have known Dr. Bahna for many years, always enjoyed seeing her at international meetings, and I admired her remarkably. So she asked me a few months ago when we were in a meeting in Europe. I was delighted and I appreciate your invitation, Bahna. I heard all the presentations, and I was very impressed by the level of knowledge that you have and experience, no doubt. Well, since Dr. Bahna became the president or the director or the chief of Abu Rish Children's Hospital, I was trained there. I spent my internship rotating there, so it was someone with memories for me. So I looked at my old photo albums for any picture that I have about memories in Abu Rish. Unfortunately, I could not find any pictures put many years ago, but while I was in that process, I came across some very interesting pictures. I will show you just a few of them. This is about my first job when I finished my internship. Well, I was, at the beginning, was not happy about my appointment because it was a rural health unit. And the person doesn't know for how long, for life, for how many years. But it was back, I look now at it, this was great memories. I loved it. Now, I love it, not at the time. So this is my first job here, and it is the unit that I worked in here, and the patients on the right side are the men, and to the left side are the women, and I was standing out proudly next to the brother of the mayor. Oh, that's a great prestige for me. He is with me, and you see the sign. Does anyone of you know where Kafr Darwish is? Anybody? Look at that. So I was very unique in that. For that village, I have to take 4 or 5 transportation from my house, or family house in Cairo. I was living in El Dahar district. So I have to take a tramway first to Midan al-Tahrir, and then I take a bus to Ben Shwaif. Then I take another car that is supposed to take only 5 persons, but the driver was packing as many as he can to go to Markaz al-Fashion. Then I pick from the Fashion another car, also multiple people, to go to Al-Fant. Then from there, the health unit there has a telephone. So I will call the telephone of the mayor to say anybody can have the last transportation, which is a donkey. So if I'm the person bringing the donkey from you, I'm waiting there until I carry, I go, and I arrive there. And I do that every week because I have to go to the weekend and go back to Cairo. So it was very humiliating at that time, but I look back at it and I say that was a great experience because it lasted only 3 months until I got a position at Alexandria University. So here is my staff at the unit. The nurse to my right-hand side and the other people, and the son of the son of one of the employees there from with her, and on the background, some people coming to get around with me, which is wonderful. But the most interesting part of this, that the rural unit was in the field, separate from the village, the residential area of the village. And they were separated by a canal. And the canal has a bridge. And this is these are some VIPs also. Obviously, the one to right-hand side is a rich man from his circumference. And this is a bridge. It's a good crossing. So we have to be careful. The doctor before me fell in that canal. But I learned that I was very careful that we crossed. And the lab technician was behind me, and he was supposed to go in front of me. Apparently behind me so that he can hold me if I went forward. It was great. It was wonderful. Truly, I enjoyed by seeing these old pictures that I shared with you. I hope I did not bore you with that. All right. So today's presentation is about the hypersensitivities to the medication that we use for hypersensitivities. So the objective is to recognize that antihistamine corticosteroids can cause allergy, something that we don't think of. And to identify the causes, there is specific preparation or preparations for them. And they have to prescribe as a substitute, not just leave the patient who are allergic and leave them alone. In general, in drug allergies, we have to know that the drug may have been taken before multiple times over the years without any reaction. Because always we or the patient say, I didn't take anything before. We like to accuse the latest thing. The reaction may have not been previously reported about the drug. Any adverse reaction, not necessarily to be allergic. And sometimes it takes years to recognize and publish the adverse effects that were not noticed in the primary studies in the drug. The reaction may be due to a concurrent illness. We tend to accuse the drugs and foods for many ailments. Whereas the problem, why did this patient take the drug? Why are we accusing the antibiotic, whereas the rash was from the infection? The reaction may be caused by a particular formulation, but not another. So the person can take the liquid form, get the problem, the tablet or the capsule form, not, or the injection, not. And it will be the same exact drug by the same company that produced them. The cause may not be the pharmacologically active drug, but due to an additives, which is a big problem. Because sometimes these additives are not written on the label. So in general, you see how the difficulty when we're dealing with certain reactions. Sometimes we behave as good police detectives. It takes time. It takes a very good, skillful, history-taking physician. Sometimes the patients look at us, why is he asking all these questions? Why doesn't he do a test or take an MRI on me and find it? And the history can be the most important. So the antihistamines, of course, number one for the allergy, very large number of them, various preparations in various ways, and widely prescribed, but almost all have provided. I assume that all of you prescribe almost on a daily basis antihistamines, and patients go and buy them. They don't need our prescription. No. easily available worldwide, and they incorporated in many medications. You find a cough preparation has some sort of antihistamine and to sedate the patient, for example. Just quickly to review with you what we learned in the medical school about the pharmacology of the antihistamines, that there are 4 receptors for antihistamines, different kinds, but the most widely used are anti-H1 receptor. So here are the groups of them, various preparations in each, and the last 2 are the more, they belong to the piperazine classes, and these are where the 2nd and 3rd generation were derived from. Side effects, plenty of them. The 1st generation, definitely, there is the sedation and various other things. We have heard about the appetite, particularly of cyproheptadine, increased at the time. Muscarinic receptors, urinary retention, tachycardia, alpha-adrenergic receptors, and the serotoninergic effects, and also the development and the other cardiac channel problems. And whenever an antihistamine discovered to have effect on prolongation of the QT wave, it is disapproved in the United States. So we know there are some side effects. These are not allergy. The anti-H2 receptor antihistamines, the side effects of them are much less. Cimetidine is probably more than the others, and they have many gastrointestinal side effects. And the prolonged use of the cimetidine in high doses may cause reversible gynecomastia in the boys and teenagers, breast tenderness in the female, or impotence in men. All these are just learned at the time of the medical school, and we have to be aware of it. We don't have to say it all to the patient, otherwise he's not going to take the medication. But at least say, well, I'll see you again in 10 minutes. Any problem that you encounter? And if the person said, yes, I know it happens in certain patients. Because if we tell the person about the side effects, they're going to get it. That is a yes, they're going to always think of it. So kind of principle anti-allergy medication, because allergy itself, that is not expected. Show you a patient here that I saw many years ago, a middle-aged lady presented with urticaria for 5 years. That's very annoying. Although urticaria by itself is not a dangerous disease, but a very irritating condition. And she has rhinitis also for many years. So she needs antihistamine for both. That's the method. The past history of nasal polyps and asthma. She reported flare of urticaria after a take of every antihistamine we tried. And you have some of them here, anti-H1 only, or a combination of anti-H1 and H2, doxepin combination, samidine anti-H2. So at that time, what we're going to do? There is no classics test for this in the skin or the blood. But I did the skin prick test with the common indoor and outdoor allergens because she has allergic rhinitis. So we logged and she is positive to multiple pollens as expected. Skin prick test with food extracts was positive to corn and wheat. So since there is no test for these preparations, I did directly oral challenge. Did a single blind, meaning I knew what I'm giving, and the patient did not know whether I was giving a placebo or what preparation, also to avoid bias. Of course, it was negative to the placebo, and not done for the two antihistamine, doxepin and cimetidine, because they were suspected to be the strongest that cause the urticaria. Positive to 5 anti-H1, market 5 preparation in front of you. Urticaria developed to each. The single blind, the patient, she did not know, but in the clinic, we just noticed that the exacerbation happened to the active drug, but not to the placebos. So she was concerned to have at least 7 preparations, 5 anti-H1, and 1 anti-H2, and 1 combination, the doxepin. That's a terrible situation for a patient that we are able to help her with this. When I asked my colleagues, the basic researchers in the lab, what is the mechanism of this? How can an antihistamine cause allergy? Could not know. Another patient, again, a middle-aged lady, no, I should say young ladies, no, it's 37 are young, with angioedema to shellfish, and she has allergic rhinitis and eczema. And within minutes of taking a hydroxyzine tablet, that's one dose, 25 milligrams, give it to any child. She developed shortness of breath and generalized severe pruritus that necessitated treatment in the emergency department. That's a terrible reaction. IgE as a tool, as a general thermometer of allergy, was not that impressively high. It was only 270 units. It has eosinophilia, and almost any drug reactions associated with eosinophilia. She also has an allergic condition that have some associated eosinophilia. Skin prick test was positive to feather, house dust mites, shrimp, as she was suspected from the history, and crab and lobster. Spirometry showed low the force expiratory volume once again, 70%, and the ratio 64%, that's low. Well, we did the skin prick testing with 7 preparations of antihistamines. See them front? We used the concentration as is of the preparation itself, whether it is the syrup. If not, there is no syrup of the tablet, we crushed the tablet and with normal saline on it, and we did. So 7 tests were done. Within a few minutes, she had pruritus, shortness of breath, and severe repetitive meaning, anaphylaxis from putting a drop of these things on her body. Not drinking, not an injection. That's from the skin test. Showed how severe the reaction is. None of the antihistamine sites showed a reaction, however. The histamine was positive, so it's an appropriate test. So there's a small part that was absorbed through the skin caused all this reaction. The blood pressure dropped, and therefore there was 60 to the stomach, the heart rate was increased, and but the oxygen saturation was fine. Then she was given epinephrine intramuscularly because the cough was very severe, and she was given an antihistamine, fexofenadine syrup, to be absorbed quickly with the itching, and she improved while she was in front of us in the clinic. She consented to blinded oral challenges and gave the placebo first, and the most suspected was hydroxyzine. That's what brought her to the emergency department. She wanted to have a placebo similar to hydroxyzine in color and taste. So we prepared the placebo to be sweetened, and a couple of people in the clinic tasted it and find that's very similar in the taste to the hydroxyzine. And we added some coloring to it so that the patient will be completely blind, will not be no reaction to that placebo. Hydroxyzine syrup, given 6 milligrams, very small quantity. Within 3 minutes, severe itching, severe bronchospasm, hypoxemia requiring musculoskeletal nebulized epidural and oxygen. This is not psychological action. This is a very objective, severe action in front of us. She was instructed to avoid the piperazine group, all of it, hydroxyzine, cetirizine, levocetirizine. But fexofenadine and doxepin were tolerated well, so at least we got a couple of antihistamines for her. When we saw these patients, I asked one of my junior colleagues, the reports in the lecture were very scarce. Very scarce, very few reports. One of them here about the French Pasquale, the Molly, a 57-year-old woman, notes that so far, middle-aged ladies who come to statistics later had scalp itching and eruption one day after applying hair dye. Well, of course, that's allergy to the dye. Did not improve on doxepin 2 days, 4 hours after hydroxyzine, given the appropriate adult dose, had generalized urticaria. The dose was increased to 100 milligrams. Isn't that what we do when the patient does not improve? We increase the dose, right? Because we believe we are treating. So give more. So it was doubled the dose, and she was given methylprednisolone without improvement. After discontinuing hydroxyzine, and she discontinued it because fortunately she was sleeping from 50 or 100 milligrams. Of course, that's no side effect. Fortunately she was sleeping, so she discontinued it. The urticaria cleared. Wonderful. So now we put our hand, verified this. He did skin prick test was negative. Some single blind test with several antihistamines negative 2, but positive to 4. I am positive to 4, that's a large number. She refused to be tested orally to 2. Nobody blames her that. So she's practically allergic to 6 preparations of antihistamines. Well, I asked the general colleague to review the literature, and over 64 years, there was 104 cases reported, and they are primarily adult, and the ratio of female 3 to 1. Individuals reacted to 1 or multiple preparations of the same or of different groups. By far, most of the reported action was cutaneous, and many patients had anaphylaxis. So to classify these patients in various ways, and this table shows the manifestations and the positive antihistamine, so urticaria, which is the most common in general, and angioedema. You look at and find cetirizine and hydroxyzine, which are from the same class, are the most common for urticaria. The generalized non-specific rash, again hydroxyzine and cetirizine, and anaphylaxis. In the bottom here, you may not see it in the back, that's why I invited you to sit in first class seats, but anymore. Anaphylaxis to anti-H2, ranitidine and mesolastine. The others are rarer. The allergic contact dermatitis, doxepin and ranitidine for more, that's anti-H2 both. A fixed drug eruption, cetirizine and dimenhydrinate, And the photosensitive eruption, the person take the drug and expose, the area was exposed to the sun, diphenhydramine, which is a Benadryl, a very serious reaction, toxic epidermal necrolysis, a very bad, as well as the acute generalized exanthematous pustulosis. Both of them are very bad drug reactions. Pain in particular, that's high mortality rate. And you'll find these two are to anti-H2, ranitidine. The severe reaction to the anti-H2 more than more to the anti-H2. So we classified them according to the class that's H2 antagonist. The ranitidine, which is the common, with 46 cases, 46 reactions. The reactions were contact dermatitis and anaphylaxis more by far than the others. Anti-H2 reactions are more likely to cause severe reactions. The other preparations, the ranitidine, samidine, famotidine, azitidine, one case and anaphylaxis. Of course, there is bias in this, because people are not going to report in the lecture mild reactions. So, the mild reactions are not coming to our attention, no harm, but the severe reactions are reported, which is worthwhile. When we look at the anaphylaxis caused by the anti-H1, although the anaphylaxis is more by the anti-H2. So the mesolastine, diphenhydramine, and dimenhydrinate, which is often used for the vertigo or for seasickness, are the main. So two preparations of particularly mesolastine is more than the others. According to the preparation, ranitidine causing anaphylaxis, and ranitidine by far 9 and 9, the others are much less. Beware of hidden food protein. You read, and we don't read everything on the label and ingredient. There is soy protein in certain preparation, the one that it melts in the mouth, and lactitol, which is derived from bovine milk also. And this may be the cause, not the pharmacologically active ingredient. So we looked into what was proven in the lecture about that. Gelatin in capsules was responsible for mutations, and it is present in numerous. Capsules are made primarily of gelatin. Lactose, which is derived from bovine milk, that's the sugar, present also in many preparations. Starch of corn or potato or rice or wheat, and all what we may find on the label, the word starch, and we don't know its source, just improper labeling. And it is present also in many preparations. Cinnamon, a nice taste and smell, present in certain syrups. Cocoa butter, in Finnergan, suppositories, which is used very frequently for the vomiting. So, conclusion of this part is that antihistamine can cause IgE or non-IgE mediated hypersensitivities, but are mostly missed because we don't think of it and we increase it to improve the allergen, which is the main reason why we're giving antihistamine. It's primarily in adults, much more in females, mostly cutaneous, but it can be life-threatening, anaphylaxis or terrible rashes. can be caused by one or multiple preparations, up to 8 preparations in certain patients happen. Anaphylaxis is more to anti-H2, most ranitidine. This has not been reported, perhaps missed. I hope it is true that no this happened, but once anaphylaxis happens and it's not treated appropriately, it can cause death, of course. And diagnosis should be suspected by the medical history and a trial of a substitute from a different class. Although the person can have allergy from different classes, but at least the same class is most suspected. Confirmed by appropriately designed titrated child to be careful. We don't give the whole dose at one time. It should be under supervision. We don't tell the person, try it at home and tell me. That's, as you saw some examples, how one of my patients, just by doing the drop on the skin, caused anaphylaxis in her. With the increasing preparations, always more and more preparation of antihistamine coming up, and the availability without a prescription in almost all countries, that's the dangerous thing for us. So you should be expecting that as people use more and more antihistamines, the more the problem is, which teaches us we don't, in drug allergy, we don't just have hazard flex our muscles and we give a longer prescription of medications. And unfortunately, most patients, they think, oh, I am better than another doctor because I prescribe a lot of medication, therefore I am bright and intelligent, knowledgeable. Wrong. The skill for doctors is to solve the problem with the least number of medications, the least tests, not the many. The more we do of medication, the more problems we get, and we mess up the problem. All right. So we go to the next part, which is the hypersensitivity to corticosteroids. Again, that's the main drug that we use in severe allergies. In various ways, whether orally by injection or topically. Actually, every specialist in medicine prescribes corticosteroids. Can you tell me who doesn't? Of course, the dermatology and the allergy, if you remove corticosteroids from the market, will close our specialties. What we're going to do without that? Neurosurgeon use them, gastroenterologist, a very good broad spectrum anti-inflammatory medication. All right. A woman with multiple sclerosis and acute optic neuritis received in the neurology department 1 gram intravenous methylprednisolone, sodium succinate. It was preceded with oral famotidine and anti-H2 and acetaminophen, which was the protocol of giving this medication. So was the chairman of the neurology department treating this lady, and he noticed that 50 minutes into the infusion of the methylprednisolone succinate, she developed generalized urticaria, periorbital edema, and severe hoarseness. The infusion was discontinued and was treated with epinephrine and anti-H2 preparation and anti-H1 preparation, and was given oxygen and given normal saline intravenous. So treating the shock. The symptoms abated within 20 minutes, and then she was referred to us with the preliminary suspects in this, all the medication that she got. If you are going to find anybody near this scene of a crime, suspect everyone. After. Not because that person looks nice and handsome. It's probably did it. We don't. So when she came to us, it's revealed that she previously received methylprednisolone succinate, still suspect. Not because she got that medicine multiple times before, still suspect. Over 11 years she was doing that. She also reported taking acetaminophen, famotidine, and interferon beta-1 alpha after the anaphylactic reaction. This shows that these medications are innocent. Happened after the reaction without causing any problem. That facilitated to know who would be suspect then, the other medicine, which is the methylprednisolone succinate. So we looked in the literature. Now, first, we did skin testing with 6 corticosteroid preparations. The first one with the methylprednisolone succinate intravenous preparation, but this is made by the same company. One of them 40 milligram per ml concentration, the other 125 milligram. The same pharmacologically active preparation by the same company. We tested them. Tested with other preparations. Of course, we put a negative control and a positive control, which is histamine. We'll find the skin prick test was positive only to the methylprednisolone succinate and negative to methylprednisolone not succinate. Negative. Intradermal was not done, of course, when the skin prick test is already positive. That's photosite. So we did the intradermal with the other preparations, also negative. So this patient showed sensitization. Whenever allergy tests, whether skin or blood, is positive, it indicates sensitization, not necessarily clinical allergy. Good. Therefore, we cannot tell the person from the skin test or blood test you're allergic to 20 things. You are sensitized. And many of us can be sensitized without disturbance of the allergic balance. So this patient showed sensitization to 2 preparations of methylprednisolone sodium succinate, but not to methylprednisolone alone, not succinate. Therefore, her anaphylaxis seemed to be to succinate ester. So we recommended that she can use corticosteroids succinate to avoid corticosteroid succinate preparations. The literature search we found 48 articles, have 120 reactions from 106 patients, but some of them got more than one, were equal in proportion males versus females. And look at the age. All ages, from 2 years to 9 years of age. No exemption. Any age can happen to this problem. If we look at classify them according to the route of administration, with intravenous by far was the most offending. And find 48 patients in that compared to the other numbers. Intramuscular fault, and on the intravenous here, look what happened. Worse as expected. Anaphylaxis is by far, and by a distance would be cardiac anaphylaxis. This is already, and the antibodies are there, and the antigen injected is going to cause the problem. Intramuscular, also anaphylaxis is number 1. Intra-articular, this is a common used by rheumatologists. Anaphylaxis, again, there is bias of report. The oral route and the intralesional by the dermatologist uses, and topical when applying 2 cases of anaphylaxis. Epidural by inhalation, anaphylaxis one. The data of the causative drug and methylprednisolone by far is the most common, and the least is the oral prednisone. So whenever we use medications that can be available orally and easily absorbed, let us go for that route. What we inject, we cannot take it back. But when we get something orally, hopefully the patient will vomit it as a part of the reaction. And if not, at least we are not going to add more. But whatever injected, I cannot retrieve it. According to the manifestations, the severest manifestation is the anaphylaxis, and it has the largest number of patients. And number one of them is methylprednisolone, followed by triamcinolone. The least of them is prednisone. The angioedema, again, methylprednisolone. Bronchospasm, methylprednisolone. Rash, methylprednisolone. Flushing, prednisolone. So, all this analysis of data show us who is the most likely to cause the trouble. One of the bad reactions is the mentioned the thin toxic dermatolysis or Stevens-Johnson syndrome. And another one is duress, which is the drug rash with eosinophilic and xenophilia and systemic symptoms. So in this case, methylprednisolone, 50 milligram intravenous, it was immediate type reaction. That is a rash with hypotension, is anaphylaxis. And later, the onset of delayed type can be both types. TNF alpha inhibitor intercept and that caused marked improvement because the treatment of duress is steroids, systemic steroids. That's where the rash and the organs are affected, particularly the liver, and the treatment is not as bad as toxic dermatolysis. So this is a rare case that requires steroids, but the steroid causes it. So we have to look for another anti-infective. The active ingredient that can cause, not the active molecule. The succinate ester, as I pointed before, and it is mainly in the methylprednisolone preparation, and was responsible for anaphylaxis more than other preparations. Lactose derived from the bovine milk, present in methylprednisolone, and cause also anaphylaxis more than others. Carboxymethylcellulose, triamcinolone, polyethylene glycol, which is present in many medications. In methylprednisolone, in every analysis we did, we find that methylprednisolone is the big criminal. Unfortunately, some of these excipients or additives are present in the anti-asthma medications. You find that many preparations that the name may be different here, but the active ingredients here is the combination or only steroids or long-acting bronchodilator or glucosamine. Present in them, the lactose present in all of them in various quantities. Solumedrol, and I underline the 40 milligram, remember? It's available in two formulations by the same company, 40 per ml and 125 per ml. The 40 milligram per ml has good quantity of lactose, but not the 125. So we find that the other preparation that we're using, we heard about singulars earlier, has also, but all these lactose, most of them are indicated on the label, but some of them they say contain lactose without mentioning the quantity. That is these two cases illustrate the importance of that one preparation can be the cause, but not the other of the same medicine by the same company. Two medical allergic children develop generalized urticaria following intramuscular dose of a particular formulation, solimedrol, that's the methylprednisolone. First case, a young child, she's 8 years old with asthma and atopic dermatitis and milk allergy. Presented to the emergency department with acute asthma. So we have to give the acute asthma beta agonist by inhalation, and of course a steroid. And she was given the steroid of the preparation 40 milligram per hour. Was followed by generalized urticaria. She came for the asthma, her skin fine. And here in the emergency room, the medicine was followed by generalized urticaria. What disappointment to the family. The other one is a 3-month-old child. Presented to the emergency department with urticaria on the neck. Did not improve after a dose of oral hydroxyzine because the urticaria in the neck. So what? Not because of a young baby. Of course, the mother was concerned. And has a history of allergy to milk. In the emergency department, giving solimedrol of 40 milligrams per ml that contains lactose. Was followed by generalized urticaria. Wow, I'm bringing my baby to just few urticaria on the neck. And now we give something that goes all over. Of course, they can blame the doctor, but this is hypersensitivity. But the doctor didn't pay attention. And I don't blame them. These things are just come with experience and digging for it that we know that lactose brings a certain preparation. If the person is going to ask the history and not on the label. So the skin prick test was strongly positive to milk as expected. The history showed that. The skin prick test was 5 injectable corticosteroids. Was positive in both of these two children, only to solimedrol of the 40 milligram per ml, but not solimedrol, the 125 was okay, or decadron, or prednisolone. So only solimedrol, the 40 milligram, contained the lactose and beta-lactoglobulin, which are allergens, because the person has milk. Very often we underestimate the quantity of an agent that causes hypersensitivity. We say how much is there. That's very, very little. How much of viruses is there? Do we see a virus? Do we see it with an ordinary microscope? And only we see it as a little tiny black spot with electron microscope that needs a super specialist in biology to figure out what kind of virus is that. But do we smell it? Do we see it? Can kill thousands? Yes. The immune system sometimes react or hyperreact to these small food antigens or a drug antigen in a way that's devastating, like a virus invading. 2 children with a history of severe milk allergy presented at the emergency department with acute asthma. Anaphylaxis followed. The solimedrol, the corticosteroids, that's the treatment for that. Case 1 received nebulized salbutamol, 40 milligram again methylprednisolone, but the wheezing deteriorated. Again, let's examine his mind. Medication caused the trouble. Rather than go and increase the dose and give more of it, and the same thing for the second patient. Skin testing was positive only to Solmedrol 40 milligram. The pathogens, again, the mechanism. From the nature of the reaction, it is immediate, but it's within minutes. So it has to be IG mediated, particularly from the intravenous preparation. That's the nature of the symptoms and the speed, the time of onset and that. But some cases, the test was not positive. We can attribute that most of the drugs are low molecular weight. That needs to be attached to a protein, intrinsic protein in the body. They act as haptens. That when the drug mixes with the protein which in my body become larger molecular weight and can stimulate the immune system. Therefore, skin testing is not surprising that it's negative. I'm not testing with a combination, it's with the hapten only. Cardiotoxicity can happen from some intravenous preparation. We always advise the nurses and the interns and the residents, whenever you inject intravenous something, go slowly. And if you are giving infusion, once a reaction happens, stop quickly. That's much easier than oral or intramuscular, because I cannot take it out. But infusion, I block and wait. See what happens in the reaction, whether I need treatment or I go more, because some of these reactions are psychogenic. So identification of the cause of the drug history is the most important. Lab test may be helpful, but very limited. Skin testing for some drugs causing IG-mediated reactions, patch testing mainly for type 4 reactions, the same mediated. Blood test mostly experimental. Suboptimal will find that the basophil activation test is being marketed and the reliability varies widely and needs special expertise in it. So the challenge is the most definitive. Should be based on sound design, how much I'm going to give, and that include a placebo. However, if the drug is highly suspecting of causing a severe reaction, Stevens-Johnson syndrome, toxic epidermal nephrosis, breast, I should not touch that patient with that drug or similar drugs of the same class, because it's very dangerous that we do that. To that, I would just avoid those drugs. Therefore, relative to their worldwide common use, for many diseases, corticosteroids to be rarely a cause of immediate hypersensitivity, but probably they are markedly missed, are not diagnosed of harm, particularly since they are the major therapy for allergy. We are treated with it. And we assume these are the good medicines. Immediate hypersensitivity corticosteroid reactions can occur at any age. There were 290, and we showed you an infant was 2 months old. And the estimated prevalence is wide, but this is a very hypothetical figure, right? And the last item, that any corticosteroid preparation can cause that, but the most criminal in the literature is the methylprednisolone followed by prednisolone. The culprit can be the pharmacologically active drug, but can be the excipient or an additive. It needs a good detective work from us. The skin text with multiple preparations supplemented with graded, carefully administered the challenge would identify alternative safe preparation. I did not find any case in the literature that required to desensitize. We can desensitize to any drug actually by very careful design and giving it very slowly. But since there are other preparations for antihistamines or corticosteroids, rarely we need that, unlike antibiotics with the sensitivity of the bacteria. Thank you.